following lecture is aimed for senior dental students, interns, dental trainees, oral surgery and oral maxillofacial surgery residents, as well as master and doctorate degree candidates. In memory of my late parents, may Almighty merciful God rest their souls in heaven and peace. So first of all, please allow me to give a brief bio about the speaker. My name is Muhammad Ahmed Al-Shulqami. I'm currently a professor and the chairman of the Oral and Maxillofacial Surgery Department at the Faculty of Dentistry, Suez Canal University in Ismailia, Egypt. Actually, Ismailia is one of the most beautiful cities in Egypt. It is located around 80 miles to the eastern of Cairo, overlooking the Timsah or Crocodile Lake and Suez Canal. Ismailia was founded by and named after one of the great rulers of Egypt in the 19th century. He was Ismail Pasha or Khedive Ismail. He was the one who did the opening ceremonies of the Suez Canal in 1869. Beautiful scenery is always seen in Ismailia. You have a greenery landscape overlooking lovely blue sea, and I think it's worth visiting. And that's the place where I work. This is the Faculty of Dentistry complex. It is comprised of 3 main buildings. I'm also the professor and the supervisor of the Oral and Maxillofacial Surgery Department at Faculty of Dentistry, Sinai University, Kantara campus in Ismailia. I also worked as a part-time associate professor at MIU University and MSA University for several years. I'm a visiting professor at the Faculty of Dentistry, Beirut Arab University, in the Oral and Maxillofacial Surgery Department in Beirut, Lebanon. I'm also the managing director of the Egyptian Dental Center, a multi-speciality discipline dental and maxillofacial center based in Cairo, Egypt. And the topic of our lecture today is the management of maxillofacial infections, talking about mandibular facial spaces, part 1. Our main ILOs are knowledge of different mandibular spaces, understanding the different routes of infection for each space, understanding the clinical significance of each space, last but not the least, knowledge of the clinical picture and the management or surgical incision for each space individually. So let's first know what are the muscles governing the spread of infection when it comes from the mandibular teeth. We have the mylohyoid, the masseter muscle, medial pterygoid, superior constrictor of pharynx, and last but not the least, orbicularis oris. Furthermore, we have the depressor anguli oris muscle, or sometimes it is called the triangularis, the depressor labii inferioris, or it is also referred to as quadratus labii inferioris, and last but not the least, the mentalis muscle. And now let's take a brief tour to show diagrammatic presentation of these muscles. The first red arrow points to the masseter muscle, and the second one points to the medial pterygoid muscle. And these two muscles, they are on either side of the mandibular ramus, and they form what is called the pterygomasseteric sling. And along with the mandibular ramus, they form the submasseteric space in between the masseter muscle and the lateral wall of the ramus. And on the other hand, medially, between the medial pterygoid and the medial aspect of the ramus, we have the pterygomandibular space. The third arrow points to the superior constrictor muscle of the pharynx, which forms the lateral wall of the pharynx. And along this muscle, we have the parapharyngeal spaces, the lateral pharyngeal space on the lateral aspect of the superior constrictor of the pharynx, and the retropharyngeal space is the one which is located behind the pharynx. On the left hand side, we can see a diagrammatic representation of the lingual or the medial aspect of the mandible, showing the mylohyoid line. And you can notice that the mylohyoid line goes upwards or superiorly as long as we go towards the posterior teeth or the molar teeth, which means that teeth like the second and the third molars, having their apices mostly located below the attachment of the mylohyoid muscle, and infections from such teeth, when they erode the lingual cortical plate of bone, will eventually lead to submandibular space infection below the attachment of the mylohyoid muscle. On the contrary, anteriorly, when the premolars or the first molar might be involved, lingual erosion in the cortical plate will lead to sublingual abscess. On the right hand side, you can see the attachment of the buccinator muscle to the buccal cortical plate of bone opposite to the maxillary molars, and the buccal cortical plate of bone opposite to the mandibular molars, and accordingly, if the infection erodes below the level of the attachment of the buccinator muscle, it is going to lead to a buccal space infection. If it erodes above the attachment of the buccinator muscle in the lower jaw, it is going to lead to a buccal vestibular space abscess. And here come the muscles of facial expression governing the spread of infection in the anterior region. We are going to find them labeled in green. On the right hand side, you can see the depressor labii inferioris muscle, or the quadratus labii inferioris. In the middle, we can see the triangularis muscle labeled in green, or the depressor anguli oris. And on the left hand side, you can see the mentalis muscle. And according to the order of infection with respect to the offending tooth, we can classify facial spaces into primary or secondary. Where the primary facial spaces, the infection spreads directly from the offending teeth to this space, which lies in vicinity or anatomical vicinity to the offending teeth. On the other hand, the secondary facial spaces, the infection spreads further to these spaces from the primary one. So to recapitulate, the primary facial spaces take the infection directly from the offending teeth, and through their communications to other facial spaces, the infection spreads to the secondary facial spaces. And now let's go through an overview of the different mandibular facial spaces related to infections spreading from the mandibular teeth. First of all, according to the anatomical location, we are going to divide them into the space of the body of the mandible, or the perimandibular spaces, or the masticator space. The perimandibular spaces are the submandibular, sublingual, and submental spaces, and the masticator space are the ones who are located in or around or between the different muscles of mastication, like the submasseteric, pterygomandibular, superficial temporal, and deep temporal space. On the other hand, according to the order of infection, directly from the teeth, or the infection is spreading from a primary space to a secondary space, we can furthermore divide them into primary mandibular spaces like the submental, the buccal, the submandibular, and sublingual. And furthermore, the secondary facial spaces are the masseteric, pterygomandibular, superficial, and deep temporal, lateral pharyngeal, retropharyngeal, and prevertebral. However, in some instances, some spaces might not like the secondary role, and they might present themselves as the key prime player, or the primary facial space where the infection first invades. And of course, this depends upon where the infection comes from. Here we can see the masseteric or pterygomandibular, or even the lateral pharyngeal, might be regarded as primary mandibular spaces. When the lower wisdom tooth, or the lower third molar, is involved, particularly when it is mesioangulary or horizontally impacted, we can see on the left hand side of this panoramic view, the red arrows are pointing to a large, huge cavity, distal cavity in the lower second molar, and a very large carious cavity exposing the pulp in the lower horizontally impacted third molar. And so, according to the direction of the wisdom tooth, whether it is horizontally or mesioangulary impacted, or vertically, and the depth of impaction, whether it is partially impacted or a little bit superficial or a little bit deep in the muscle, and furthermore, the lingual or the buccal deflection of the roots itself, it will dictate where the infection will go further. That the lower third molar is regarded as the jack of all trades. It can go to different destinations, whether it depends upon the infection is coming from a pericoronary infection or a periapical infection. On the right hand side, you can see a coronal section showing the different destinations where the infection can go from the lower third molar to the sublingual space if the pericoronary infection gets above the level of the mylohyoid muscle, or into the submandibular space from a pericoronary infection or a periapical infection. On the buccal hand side, we can see a pericoronary infection might lead to a buccal space infection or a vestibular space infection, and the periapical infection will definitely get into a buccal space infection. On the left hand side, you can see a a horizontal or axial section showing the different posterior destinations from the lower wisdom tooth, it can go in the submasseteric space or furthermore lateral to the masseter space, where it can dig through medially through the pterygomandibular space, or even more far medially, medial to the medial trigonoid muscle into the lateral pharyngeal space. What are we going to discuss talking about each space? First of all, we have to know the anatomical boundaries of this space, and accordingly we should know the routes of sources of infection for this space. Then we will discuss the clinical significance or clinical relevance through the following points: the contents of the space and the communications of this space to the neighboring spaces or the secondary spaces, and last but not the least, the clinical picture of involvement of these spaces. And last but not the least, we are going to go through the management, or particularly the surgical incision of these spaces, because the management, of course, is a more broader term, including strategic planning and strategic management of the case as a whole. And first of all, we have to deal with the cause of the infection, either with the endodontic treatment or surgical extraction. So removal of the cause is one of the key features or key factors in managing the cases of infection, and it will be discussed in a separate video. And now let's focus on the topic of our lecture, the perimandibular spaces, which are the submental, the submandibular, and the sublingual. First, let's start with the submental space, which is a potential space located between the mylohyoid muscle superiorly and the platysma muscle lies inferiorly. This space, it is located in the midline under the chin. That is to say that we have only single submental space. And anatomically, this space coincides with the anatomical region termed the submental triangle. And the submental triangle is part of the anterior triangle of the neck. On the right hand side, we can see the submental space labeled in yellow color with different anatomical structures related to it. So what are the anatomical boundaries of the submental space? Submental space is bounded by the mylohyoid muscle superiorly and the investing layer of the deep cervical fascia, which is covered by the platysma muscle, comes inferiorly. The lingual aspect of the inferior border of the mandible lies anteriorly, and the hyoid bone lies posteriorly, and on either side laterally it is bounded by the anterior bellies of the digastric muscle. What are the communications of the submental space? It communicates posterolaterally with the submandibular space and the sublingual space superiorly, where erosion might happen through the mylohyoid muscle. And the submental space contains the submental lymph nodes and area loose connective tissue and the anterior jugular veins. What are the sources of infection for the submental space? Odontogenic infection related to mandibular anterior teeth are the main source of infection. However, according to the erosion of the bone from the anterior teeth, whether it is lingual or labial, and according to the level at which this erosion happens, it will decide where the infection will go. So from the lingual aspect, if the infection erodes the bone above the level of the attachment of the mylohyoid muscle, it's going to result in sublingual space infection. And if it goes below the mylohyoid muscle attachment, it will lead to submental space involvement. On the other hand, erosion of the labial plate below the mentalis muscle will lead to submental space infection. However, infection of the submental space usually comes first by involvement of the submandibular space, and then it spreads to the submental space. Whereas cutaneous infections or furthermore compound fractures related to the symphyseal or parasymphyseal region might also give rise to submental space infection. And this diagram shows the mandibular anterior teeth and the level of the attachment of the mentalis muscle from the labial aspect and the level of the attachment of the mylohyoid muscle from the lingual aspect. And typically when pus erodes the labial plate of bone below the mentalis muscle attachment, is going to result in the submental space infection, Likewise, from the lingual aspect, any infection getting underneath of the mylohyoid muscle will result in submental space infection as well. So what is the clinical picture of the submental space infection? On both figures we can find a large firm swelling below the chin area. It might be hard or a little bit fluctuant. You might have, like on the right hand side, a redness or erythematous halo, or you might not find that. Usually the patient complains from dysphagia, which is difficulty in swallowing. What about the management or the surgical incision of the submental space infection? In case of pus accumulation, the space needs to be surgically incised and drained. On the right hand side, the lower figure, we can see a diagrammatic representation of the incision placement, and on the upper figure we can see the diagrammatic representation of the submandibular and submental and other spaces. The incision usually runs in a transverse horizontal fashion. It should be placed in a skin crease behind the chin to avoid obvious scarring afterwards, and before the incision the local anesthesia is given in a field block fashion all around the area or the inflamed area, but it is given in sound tissues without involvement in the infectious process. The submental space derives its importance as it is one of the spaces involved in what is called Ludwig's angina. Ludwig's angina is a progressive cellulitis which involves submandibular, sublingual and submental spaces bilaterally. It is a very serious condition, and one of the most serious situations that you can face regarding maxillofacial infection. It can lead to pharyngeal and cervical spaces spread of infection, and the swelling can lead to edema, and it can compress the airway starting with dyspnea, and it might end with suffocation and the patient cannot breathe totally. The sublingual space. On the right hand side you can see clinical photos of sublingual space infection. The sublingual space is the potential space. It is located in the floor of the mouth. It is below the mucosa of the floor of the mouth, and it is above the mylohyoid muscle. It is considered part of the suprahyoid group of facial spaces, and of course it is a bilateral space. Here is a diagrammatic representation of the submandibular and sublingual space. The sublingual space is labeled in green and the submandibular is labeled in light yellow, and it shows the relation between them. The mylohyoid muscle is the main separation between the sublingual and the submandibular spaces. You can see the hyoglossus muscle, the contents of the sublingual space like the lingual nerve and lingual vein and lingual artery, and the sublingual gland and the duct of the submandibular gland, and on the submandibular space you can see the submandibular gland and the facial artery and vein. So what are the anatomic boundaries of the sublingual space? The sublingual space is regarded as a V shape where the apex is pointing to the anterior. Superiorly we can find the mucosa of the floor of the mouth and the tongue as pointed to by the black arrow, and we have the mylohyoid muscle inferiorly, and we have the medial surface of the mandible anterolaterally. Moreover, posteriorly we have the muscles along the base of the tongue, which are the geniohyoid and genioglossus muscles. And on the medial aspect we find the intrinsic muscle of the tongue, where the genioglossus muscle separates the two halves or bilateral aspects of the sublingual space. What are the communications of the sublingual space? The sublingual space communicates around the posterior border or the posterior free border of the mylohyoid muscle posteriorly with the submandibular space. Also, infections from the sublingual space may also erode through the mylohyoid muscle or spread via the lymphatics to both submandibular and submental spaces. And as we said before, that involvement of the three spaces bilaterally may lead to Ludwig's angina. The sublingual space contains lots of structures. We have the lingual artery and the lingual nerve, and the 12th cranial nerve, the hypoglossal nerve, and the 9th cranial nerve, the glossopharyngeal nerve. Also we have the sublingual salivary gland and the short small ducts draining the sublingual salivary glands, which opens in a fold in the floor of the mouth called the plica sublingualis. However, sometimes a more distinctive duct can be recognized, which is known as the Barthol's duct. And this Barthol's duct, it joins the Wharton's duct from the submandibular gland near its orifice at the carunculus sublingualis, and it opens directly into this duct. Moreover, we have the deep part of the submandibular gland, which is pointed to by the black arrow, and the submandibular duct, the Wharton's duct, and also the space contains some extrinsic tongue muscle fibers. What are the routes of infection? A periapical abscess may spread into the sublingual space if the apex of the tooth involved in such abscess lies above the level of the attachment of the mylohyoid muscle. So the infection will erode the lingual cortical plate of the mandible above the attachment of the mylohyoid muscle. And we can see that the attachment of the mylohyoid muscle, as pointed to by the black arrows, it goes upwards as we go posteriorly towards the molar area. What are the clinical features of sublingual space infection? The signs and symptoms are a firm painful swelling in the anterior part of the floor of the mouth. Usually the sublingual abscess may elevate the tongue and it causes drooling of saliva, and the patient might complain of dysphagia, which is difficulty in swallowing, and usually there is little swelling visible on the face. However, it should be differentiated from any pathology arising in the sublingual gland. Although the sublingual gland involvement in pathological entities is rare, but yet the sublingual gland neoplasms are predominantly malignant and they should be recognized at once. The management and the surgical incision. If the space contains pus or accumulates pus, incision and drainage should be done, and the site of the incision is done intraorally in a horizontal fashion from posterior to anterior. It is done lateral to the sublingual plica or the plica sublingualis. On the other hand, if incision is done in the plica itself, it can result in ranula. It's going to hurt the sublingual gland. Or if the incision is placed medial to the plica, it can damage the Wharton's duct or the sublingual artery and the lingual nerve. This is a diagrammatic representation and a clinical photo. On the right hand side and on the left hand side you can see the diagrammatic representation showing the plica sublingualis and the carunculus sublingualis, which is the place where the orifice or the opening of the Wharton's duct from the submandibular gland opens, and this is the lingual frenum also on the sublingual fold. So when you come to incise the sublingual abscess, it should be done on the lateral aspect of the plica sublingualis, just close to the lingual border of the mandible. As previously mentioned, collectively the submandibular, sublingual, and submental spaces are termed the perimandibular spaces, and they derive their importance being the key players or the prime spaces involved in what we call Ludwig's angina, where we have involvement of the three spaces, the submandibular, sublingual, and submental spaces bilaterally. In this infection, it's a serious form of maxillofacial infection. It might lead to difficulty in breathing and dyspnea, and furthermore, if not treated, it may compress the airway and cause suffocation. And now let's go to the submandibular space. It's a paired space on either side. It is a potential space. It is located superficial to the mylohyoid muscle and lies between the anterior and posterior bellies of the digastric muscle. From the anatomic perspective, it corresponds to the anatomic region termed the submandibular triangle, which is part of the anterior triangle of the neck. And here you can find in the figures it is labeled in green. In this diagrammatic representation, we can see the sublingual space labeled in light green and the submandibular space below it or below the mylohyoid muscle. It is labeled in light yellow. It is bounded by the platysma muscle from the inferior aspect, and superiorly it is bounded by the mylohyoid muscle. It contains the submandibular salivary gland, the facial artery and vein. What are the atomic boundaries of the submandibular space? It is bounded superiorly by the mylohyoid muscle and inferiorly and laterally it is bounded by the skin, superficial fascia, and platysma muscle, and the superficial layer of the deep cervical fascia. And you can see that clearly in the right hand side figure. Moreover, the medial surface of the mandible is located anteriorly and laterally, and the hyoid bone bounds the space posteriorly, and medially it is bounded by the anterior belly of the digastric muscle. Coming to the contents of the submandibular space, the larger of which is the submandibular gland, which largely fills the space. We also have branches of the facial artery and the submandibular lymph nodes. The communications of the submandibular space are medially and anteriorly. It is connected to the submental space, which is located medial to the paired submandibular spaces, and it's only separated from them by the anterior bellies of the digastric muscles. Posteriorly and superiorly, it is communicated to the sublingual space, which is located above the mylohyoid muscle, and inferiorly it communicates to the lateral pharyngeal space. What are the sources of infection of the submandibular space? Usually it comes from the mandibular molar teeth. Odontogenic infections from these teeth will erode the lingual cortical plate of bone, and usually in order to go to the submandibular space, the erosion should be below the attachment of the mylohyoid muscle. And if we look on the diagram on the right hand side and on both the black arrows pointing to the attachment of the mylohyoid muscle, and we notice that the mylohyoid muscle attachment goes upwards and more superior as long as we go posteriorly. So the second and the third molar teeth are more likely to cause the submandibular space infection when the infection erodes the lingual cortical plate of bone below the attachment of the mylohyoid muscle. What is the clinical picture of the submandibular space infection? The signs and symptoms include swelling in the submandibular region or the submandibular anatomic triangle, and inability to palpate or feel the inferior border of the mandible. There is on the right hand side figure we can see the swelling obviously. Sometimes it is associated with redness and sometimes not, and of course there is no trismus unless there is involvement of the masticator, one of the masticator spaces posteriorly. And the surgical incision of the submandibular space, it is done extraorally and usually made 2 finger breadth, about 2 to 3 centimeters below the inferior border of the mandible, and it should go parallel to the inferior border as well, or sometimes it is placed in skin creases to avoid facial scarring. And as previously mentioned, the submandibular, sublingual, and submental spaces derive their importance from being involved bilaterally in the Ludwig's angina, a serious infection or a serious form of maxillofacial infection which might lead to closure of the airway. And now let me tell you about happiness. It is not in doing what you like, but in liking what you do is the secret of happiness. And finally, I would like to thank you for your kind attention. Thank you so much.